Guys, the second question here, it says that choose the correct statement regarding the interossei muscle in hand. Now this I have to consider as one of the most important question in the recent year, because the lumbricals and interossei are heavily asked in the Central Institute also, as well as in the NEET exam as well. So before we get into the options of this question, let's have a little discussion regarding the interossei muscle and how they are displaced in the hand. So here again I'm using this picture here. Now you're looking at a set of a palmar interossei and the dorsal interossei. Palmar interossei can be 3 or 4, maybe like it can be 3, it can be 4 also. So there are 3 to 4 palmar interossei that we have, and we have a 4 dorsal interossei. A thing to be noted from the diagram itself, that the all palmar interossei, they are unipinnate. As you can see from the diagram itself, that the palmar interossei are unipinnate, whereas dorsal interossei are bipinnate. You can see the dorsal interossei, they are originating from the contiguous side of the metacarpal. So these are the bipinnate muscles. Well, one famous mnemonic for this, for the interossei is, we say that pad and dab, isn't it? That's how we remember them, pad and dab. That means palmar interossei, the function is what? Adduction, and dorsal interossei action is abduction. And when you talk about the adduction and abduction in the hand, we obviously consider the middle finger as the principal digit here. So guys, if this being a middle finger here, obviously the action of palmar interossei is to bring other finger close to the middle finger in this manner. And because dorsal interossei is for the abduction, so the function of the muscle is to take other fingers away from the middle finger, right? Now, if you see, I said that why there are 3 or maybe 4 palmar interossei in the hand, why there is a 4th one, or why it may be absent. The reason is that thumb, actually there is no need for palmar interossei for the thumb. Thumb is already having a very strong muscle called as a adductor pollicis. And it's a very, very strong muscle, because adductor pollicis is having a transverse head as well as oblique head. So there's a huge muscle which is there for the adduction of the thumb. So we may not need additional muscle for the adduction of thumb here. So that is the reason in human, the first palmar interossei, that means the palmar interossei for the thumb, it may or may not be present. It may or may not be present. So that means you have this palmar interossei here, it is going toward the index finger. The second one is going toward the ring finger, and this last one is going toward the little finger. And you can see how the muscles are oriented. They are basically pulling all these muscles close to the middle finger here, which tells me that middle finger is devoid of palmar interossei. There is no palmar interossei on the middle finger. You can see that, because the rest of the fingers needs to come close to the middle. Middle finger need not move here. Similarly, when you look at the dorsal interossei, the action of dorsal interossei is abduction. Now first, where dorsal interossei would be absent? When you think of the muscle abducting the fingers, we already have a strong abductors for the thumb and for the little finger. Like we have a muscle called as abductor pollicis longus as well as abductor pollicis brevis. So we got 2 muscles which are for the abduction of thumb. And similarly, we have a muscle for the abduction of little finger called as abductor digiti minimi. So once again, I can say that if there is an abductor for the thumb and for the little finger, these 2 digits don't need the abductor, they don't need a dorsal interossei. So the digits which do not have dorsal interossei, it is the thumb, this one, and the last one. As you can see, we do have origin of the dorsal interossei from the respective metacarpals, but on the digits, they're not present. So if you look at this one, this first dorsal interossei is pulling away the index finger, the last one is pulling away the ring finger, and the remaining 2 dorsal interossei, they both are attached to the tendon of the middle finger here. And that is the answer to our question as well, that if you look at the middle finger is the one which is having double dorsal interossei. It's a very recent question in AIIMS only. Double dorsal interossei. We have 2 dorsal interossei for the middle finger. And the one which are not having it is the thumb and the little finger, right? If I go back and read those options for you again from this question, so it says that choose the correct statement. We got to choose a correct statement here, guys, regarding the interossei. The first statement says middle finger has 2 palmar interossei. No, it was having 2 dorsal interossei. Thumb is devoid of dorsal interossei. Yes, thumb is devoid of dorsal interossei, and that will be the correct answer. And why thumb is devoid of dorsal interossei? Because thumb is already having a very, very strong abductor called as abductor pollicis longus as well as brevis. Let me read other options also. Little finger is devoid of palmar interossei. No, little finger is having palmar interossei was not present on the middle, so this option is also incorrect. And index finger has palmar interossei but dorsal interossei is absent. No, again it is incorrect because index finger is having both palmar as well as dorsal interossei. So whenever you think of what is absent or what is present, you just have to think about the thumb, little finger, and you have to think about the middle finger here. Index finger and ring finger, there is no question about it. They both have interossei, palmar as well as dorsal interossei. So answer to the question number 2 is B. Question number 6, guys. Question number 6, it is a question from the lower limb osteology. It says the incorrect regarding the marked region in the given image of the femur here is. Now, when you're looking at a picture of femur bone, the first thing you need to keep in mind is whether you're looking at the anterior aspect or the posterior aspect of the femur. Because the head of the femur or the neck of the femur will look more or less the same only. So you have to look at the trochanters, the greater and the lesser trochanter, and that will give you an idea about it. Lesser trochanter is not very well seen from the anterior aspect because it is located more inferiorly and posteriorly. So if you look at this lesser trochanter, is very well seen in this picture here. Greater trochanter can also be seen, which is more toward the lateral side, of course. And between the greater and lesser trochanter, you're not seeing just a line here. It's a big elevation that you see here, which is called as intertrochanteric crest. If this would have been the anterior view, so it must be only the intertrochanteric line in between. Now we are having a crest or this elevation between the greater and lesser trochanter, that is an intertrochanteric crest. So this obviously is the posterior view. This is a posterior view of the femur you're looking at. This is the posterior view. Now on the greater trochanter to the side here, see when you look at the anterior aspect of the greater trochanter, the muscle over there is a gluteus minimus muscle present over there. And that's why the gluteus minimus muscle, it helps in the internal rotation because it is more anteriorly placed. More toward the lateral aspect of greater trochanter, there is an insertion of the muscle that is the gluteus medius. That's a gluteus medius muscle. On the intertrochanteric crest, there is a quadrate tubercle present over there, which is giving insertion to the quadratus femoris. Obviously not quadriceps femoris, quadratus femoris. It's one of the gluteal muscle present below the inferior gemelli. That is called as a quadratus femoris muscle. And this here is the lesser trochanter. And lesser trochanter give insertion to the iliopsoas. Iliopsoas, the iliacus and psoas major having a common tendon below, the iliopsoas muscle will be inserted to the lesser trochanter. So basically, lesser trochanter, as I said, is more posteriorly. So these iliopsoas muscle will come from the anterior aspect and then turn backward like this. And that's why, despite of having a small extent beyond this hip joint, these muscles can very effective, hip flexors, because they have a good torque which is acting as if they are inserted onto the lesser trochanter. And what you see extending from the greater trochanter downward toward this linea aspera here, this region, this tuberosity here is called as the gluteal tuberosity. And guys, this gluteal tuberosity is giving insertion to the gluteus maximus muscle. The largest muscle in the human body is having its main insertion on the iliotibial tract and also on the gluteal tuberosity. So once we find out the muscles attached to these marked region, now we can go into the question here. So it says incorrect regarding the marked region in the given femur. Option A says injury to the muscle A attached here leads to a Trendelenburg gait. Well, that is correct. We all know that gluteus medius injury can lead to the Trendelenburg sign, Trendelenburg test. You all must be knowing about it. When you raise one leg, you can see that your pelvis will tilt down onto that side if your other side gluteus medius is not working, because gluteus medius is a abductor of the hip joint. So it basically keeps the pelvic bone in the horizontal plane with respect to the floor. So if the gluteus medius of one side isn't working, so obviously if you raise the leg on the other side, your pelvis will tilt. So that is called as a Trendelenburg sign or Trendelenburg test, the name given to the test here. Option B says insertion of the quadratus femoris. That is also correct here. That is also correct. Quadratus femoris muscle is inserted onto this quadrate tubercle on the intertrochanteric crest. Option C says attachment of the hip flexor. That also is correct, guys. I told you that iliopsoas muscle will come from the anterior aspect of this femur, and then will insert, like, slightly turn backward and insert onto this lesser trochanter. And option D says the muscle attached to the here at this point B is supplied by superior gluteal nerve. Well, that's not correct, because the muscle here is what? Gluteus maximus at point D, and gluteus maximus is solely supplied by the inferior gluteal nerve. It is supplied by the inferior gluteal nerve. Superior gluteal nerve supplies what muscle? It supplies gluteus medius, gluteus minimus, it supplies tensor fasciae lata, but inferior gluteal nerve is only supplying the muscle gluteus maximus. So the answer to our question is D. The answer to the question is D. Question number 10, guys. The next question, question number 10. All the given options regarding encircled region in the given skull are correct except. Okay. Now, as we all know that you look at this picture here, this given circle here is showing the point of many sutures are meeting in there, and many bones are forming this region, and this region is called as a pterion. That's a pterion. You got a pterion, like we have a pterion, asterion, bregma, lambda. So this is a pterion region here. Now, what are the bones which are forming the pterion? Now, as you can see, there is a contribution coming from the frontal bone, from the parietal bone, from the temporal bone, and from the sphenoid bone. If I just try to mark it in this way, so this here is the frontal bone, which is like contributing in there. So it's a frontal bone here. The bone that you see coming from here, that is a parietal bone. This here is the parietal bone, which is contributing to it. This here is the temporal bone. This is the temporal bone, the squamous part of temporal bone. And the bone which is coming from below here, this is the greater wing of the sphenoid, which is also contributing to it, coming from below. So 4 bones which are contributing to it is a frontal bone. We got a parietal bone. We got a squamous part of temporal bone, and we have a sphenoid bone. But what sphenoid? That's a greater wing of the sphenoid. Lesser wing of the sphenoid anyway is not on the outer side. It's a greater wing of the sphenoid in there. So that's the 4 bones which are fusing together at this point and forming this pterion here. Let me go with the options here directly, guys. We have to find out the incorrect option here. All are correct except option A says found by the greater wing of sphenoid, squamous part of temporal, parietal and frontal bone. Correct. That's what we said. It's related to the parietal branch of the middle meningeal artery. Yes, we know that middle meningeal artery is related to this point of pterion, where it can be involved in the extradural hemorrhage also. But you got to look at the word here, that is the parietal branch. No, it's not. Middle meningeal artery, when it enters through the foramen spinosum, then middle meningeal artery divides into 2 branches. One branch of middle meningeal artery which goes posteriorly, this is called as the parietal branch, and the one branch which goes to the pterion here, this is called as the frontal branch here. So it's not the parietal branch, guys, it is the frontal branch of middle meningeal artery which is related to this point pterion, and that's why this is the answer to this question. It is incorrect. Parietal branch nahi, it's a frontal branch of middle meningeal artery. Fracture in this region may cause extradural hemorrhage. Yes, that is because of the frontal division of middle meningeal artery, and located in the anterior end of the squamous suture. Yes, temporal bone and parietal bone, they are separated by the suture here, and this suture here is called as the squamous suture. It's a special type of suture. You know, they are fibrous joints in which these bones are kind of slightly overlapping each other, and then they are connected by the sutural ligament. So the type of suture here between the parietal and this temporal bone is the squamous type of suture, where the bones are slightly overlapping each other. So answer which is incorrect here is B only, related to the parietal branch of middle meningeal artery is incorrect. Question number 19, guys. Incorrect regarding the attachment of marked head of the pterygoid muscle. See, one of the reason I have included this question in this paper is because, as I said, this muscle of mastication is a question which is they are asking it repeatedly. Almost every exam or every alternate exam, there is one question on muscle of mastication, and especially on the pterygoids, lateral pterygoid being their favorite here. So once they keep on asking a certain question over and over again, what they have next, what can they ask next is like asking more detailed question about their attachments. And you know, if somebody understands the attachment in detail, then no matter what kind of section you give it to him, like transverse or coronal section, you can still make out, because you know that all the heads of these muscles, so you know which bony prominences they are attached to. So once again, I'll discuss this picture with you first and then we'll go into it. When you talk about the two muscle, lateral pterygoid and medial pterygoid, we usually talk about there is one lateral, one medial pterygoid muscle, but guys, both the muscles are having two separate head. Like lateral pterygoid is having you can see a superior head and inferior head, and medial pterygoid is having a deep head and the superficial head. There are two head, deep and the superficial head. Now this upper head and lower head. If you see the upper head, it is actually attached to the greater wing of the sphenoid. What bone is that? That's a greater wing of sphenoid. And on the lower surface of greater wing of sphenoid, there is a crest, which is called as infratemporal crest of greater wing of sphenoid. Infratemporal crest of greater wing of sphenoid, which is giving attachment to the upper head of what? Lateral pterygoid. That muscle is lateral pterygoid. दिख रहा clearly आपको. Whereas this B, lower head of lateral pterygoid, is attached to the lateral surface of lateral pterygoid plate. I told you, lateral pterygoid plate is giving attachment to both lateral pterygoid and medial pterygoid. But this one is a lateral head of lateral surface of lateral pterygoid plate is attached to it. So that's about what muscle? Lateral pterygoid. One is to the infratemporal crest to the greater wing of sphenoid, and one is to the lateral pterygoid plate ke lateral surface pe. Medial pterygoid muscle, we have two heads. One head that you're seeing here, the deep head, it is actually coming from the medial surface of lateral pterygoid plate. Again, plate is which one? The lateral pterygoid plate, but which surface? Medial surface of lateral pterygoid plate. And the other head that you're looking at here is, you can see it is coming from the most posterior part of the maxilla, and the most posterior part of maxilla here shows a tuberosity, which is called as a maxillary tuberosity. So maxillary tuberosity is also giving attachment to the head of the medial pterygoid muscle. Let me read these options for you. We have to find the incorrect in there. Like it says, upper head of lateral pterygoid originates from infratemporal crest. Correct, guys. Infratemporal crest, it is a part of what bone? It's a part of the greater wing of the sphenoid. It is a part of the greater wing of the sphenoid bone. Lower head of lateral pterygoid originates from lateral surface of lateral pterygoid plate. Absolutely correct. So both the points about the lateral pterygoid muscle is correct. Option C, deep head of medial pterygoid originates from medial surface of lateral pterygoid plate. Correct. Medial surface, but plate kaun sa hai? Lateral pterygoid only. And then it says superficial head originate from pterygoid hamulus. No. Pterygoid hamulus is an extension which comes from medial pterygoid plate. And we have kept the medial pterygoid plate out of the context when it comes to muscle of mastication. We just said superficial head is coming from where? From here. And that tuberosity is called as what? This is called as the maxillary tuberosity. We also have a pyramidal process there. Maxillary tuberosity, yaad rakho, that is enough. Maxillary tuberosity is giving origin to the superficial head of medial pterygoid muscle. If you remember these attachments in bit detail, I'm pretty sure that even the sections, transverse and coronal sections, it will be a bit easy for you to identify that what muscle you're looking at. Next in the line, question number 29. Guys, question number 29 says, which of the following option is incorrect regarding the marked structure in the given radiograph? Well, let me just, before going to the option here, let's look into this closely into this radiograph and see what exactly is marked over there. Okay, so again, I hope you can easily identify the corpus callosum in that. There we have it. This is the corpus callosum. Right? So the white matter bundle which is marked in here is basically passing below the corpus callosum. Now, if the white matter bundle above the corpus callosum was to be marked, which is in the cingulate gyrus, that would have been the cingulum fibers, right? Let me just remind you again. Cingulum fibers were those which are running like this. Cingulum fibers were running in this manner. They are like above the and around the corpus callosum, connecting the components of limbic system. The one which is marked here with this red arrow here, this is fornix. Fornix has been one of the favorite questions for the examiner in recent time. So that is fornix. The one which is marked with the red here is a fornix, guys. I'll show you the picture for the fornix. What fornix fibers does, they start from the hippocampus posterior inferiorly, then they arch above, come very, very close to each other, and then they separate the columns of the fornix, and they end in the diencephalon region. So they basically go to the mammillary body. Mammillary bodies which are present in the interpeduncular fossa. Let me show you the picture to justify that. What I'm saying is, if you just take a look here. So we are just basically here looking at this, the fornix fibers in there. So as I said, fornix fiber originate where? They originate in hippocampus. That's a fornix here. That's a fornix. So fornix fiber, they asked this question once. They originate in hippocampus. So that's the direction they're going like this in this way. And ultimately, these fornix fibers are coming to end where? They end in mammillary body. So Remember that? That's one question here. Fornix fiber starts in hippocampus and ends in mammillary body. The same mammillary body which we saw forming the floor of the third ventricle, and also is one of the content of interpeduncular fossa. You know the contents of interpeduncular fossa. We got infundibulum, mammillary body, third nerve. So mammillary body is one of the content of the interpeduncular fossa. And both these fornix, as I said, they come very, very close to each other and then they again separate. These fornix are connected to each other by this white matter bundle, and that is called as a hippocampal commissure. Talking about the commissural fibers, we said we have anterior commissure, we got corpus callosum, we have posterior commissure, we got habenular commissure, and we also have hippocampal commissure, which is connecting the posterior column or the columns of the fornix simply. So, keeping that in mind, let me just take you back to this option here. What it says is we have to choose the incorrect option, guys. We got to choose the incorrect option. So what it says, major white matter outflow tract from the hippocampus. Yeah, correct. We just said they start from the hippocampus and goes to the mammillary body, so that is correct. Option B says projects into one of the content of interpeduncular fossa. That is again correct. They go downward into the content of interpeduncular fossa. That is mammillary bodies. Is a component of limbic system? Sure it is. Limbic system, one of the main component of limbic system is fornix. Hippocampus, fornix, they are all part of a limbic system only. And then it says it runs in the cingulate gyrus, which we already justified is not correct. The one which were running in the cingulate gyrus or deep to cingulate gyrus were the cingulum fibers, which were association fibers connecting the areas of limbic system but out and around the corpus callosum. So answer to question number 29 is D. Moving on to question number 31, it says n-marked cells in the given image will differentiate into all except. So once again, guys, the same thing that we just saw, maybe in a different way. Now this, what you're looking at here below here, this is the notochord. This here is notochord. As we know, notochord, which is running in the mesoderm, it influences the ectoderm and it converts the ectoderm into the neuroectoderm. So this, the one which is shown in this light blue color here, that's a neuroectoderm only, and the neural tube is being formed here. So you can see that's a neural groove is being formed. And on the margin of this neural fold, what you'll see, we have some cells present on the crest, which is marked as N here. These are called as the neural crest cells. It's a very, very special population of cell called as the neural crest cells. And these neural crest cells are the one which are also regarded as the fourth germ layer. They are giving rise to so many structures, especially in the head and neck region, so that now we regard them as a fourth germ layer. So we have like ectoderm, endoderm, mesoderm, 3 germ layer. The neural crest cell is called as a fourth germ layer. Although the structures which are derived from the neural crest cells, we can broadly divide them in 2 categories. There are neuronal structures and we have mesenchymal derivatives. But let me tell you that what are the derivatives of neural crest cells, and then we'll come into these options here. Now I'm using a table here which you can take a snapshot of later. Now, cranial neural crest cells, guys. Our neural crest cells are all along the neural tube. So, some neural crest cells are in this region, that is a cranial neural crest cells. And the one which are along with the rest of the neural tube, along with the spinal cord, they are the caudal neural crest cells or spinal neural crest cells we have. Cranial neural crest cells giving rise to what? Now, look at these things, guys. Parafollicular cells of the thyroid and carotid cell bodies. Now, we said that parafollicular cells, we all read, they are coming from where? Ultimobranchial body in the pharyngeal arches. Well, that's not true. Actually, parafollicular cells are derived from the neural crest cells only. Odontoblast, this odontoblast, connective tissue in the eye, stroma of the cornea, ciliary muscles, pharyngeal arch cartilages, dermis and hypodermis of face and neck, sensory ganglia or the ganglias of this 5, 7, 9, 10 nerve, conotruncal septum or spiral septum, you can say, that is stroma of the pharyngeal pouches derivative. See, thing is, it's not easy to remember everything derived from neural crest cell because the list like goes on and on and on. What my suggestion to you is that when you look at the structures in the head and neck region, which corresponds to the structure which are present below head and neck. This may not be the right way to approach it, but like this usually helps to fetch the right answer. Like majority of the bones, think about the most of the bones, axial skeleton or appendicular skeleton is coming from where? From the mesoderm. But when you look at the skeleton of the head and neck region here, majority of the bones are coming from where? From the neural crest cells. When you think of the dermis, dermis of the ventral body wall, dermis of the dorsal body wall. That comes from where? Mesoderm. But when you think of the dermis of the head and neck region, coming from where? Neural crest cells. Like cartilages, coming from where in the lower part? Obviously, again, mesoderm. Cartilages, pharyngeal arch cartilages in this region are coming from where? The neural crest cells. So most of those structures, the mesodermal structures here in the below the head and neck region, in the head and neck region, they are derived from the mesenchyme of the neural crest cell. Mesenchyme derived from neural crest cells. So, if not exactly able to, remember all the derivatives here, but still you can actually eliminate options by looking at this. Other way to look at it is when you look at peripheral nervous system, guys. Peripheral nervous system is all about neural crest cells. So don't get into this sensory ganglia of the cranial nerve or dorsal root ganglia or enteric plexus or whatever it is. If you're thinking about the peripheral nervous system, once you're out of the spinal cord, the only one word that should come to your mind in most of the cases, again I'm going, that is neural crest cells. Whether it is dorsal root ganglia, whether it is a cranial, all the, nerves of pharyngeal arches, you take the enteric plexus, myenteric, Meissner's, Orbeck's plexus, all these are derived from the neural crest cells. So neural tube is about central nervous system, and neural crest cells gives rise to the peripheral nervous system, like sympathetic chain, again a part of peripheral nervous system derived from neural crest cells. Look at this, the Schwann cells. And I'm saying Schwann cells, not oligodendrocytes, because oligodendrocytes are doing the myelination for central nervous system. So that has to be from where? From the neural tube. Schwann cell is doing the myelination for peripheral nervous system. So it is from the neural crest cells. Arachnoid and pia mater. Arachnoid and pia mater, the leptomeninges, the thin meninges are derived from the neural crest cells. The thick meninges, that is a dura mater. Dura mater comes from the axial mesoderm. Dura mater is from the axial mesoderm, and leptomeninges like arachnoid and pia mater, it comes from the neural crest cells. Enteric ganglias, don't have to tell you, enteric ganglias, glia, melanocyte, and enteric ganglias, enteric plexus, they're all coming from neural crest cells. They are peripheral nervous system only, na? Melanocytes, guys, pigment epithelium is also derived from neural crest cells, except retinal pigment. Remember that retinal pigment is coming from the neural tube itself. It is coming from the neural tube only. But apart from that, if you think of any other pigment epithelium, they're all derived from the neural crest cells. Once again, look at this. Spinal neural crest, spinal ganglion, doesn't matter. It is a part of peripheral nervous system. Sympathetic ganglia, peripheral nervous system. Adrenal medulla, not adrenal cortex. This is adrenal medulla, which is derived from the neural crest cells. And some neurosecretory endocrine cells also. On the heart and lung, they are also derived from neural crest cells. I mean, you obviously don't have to remember all of them, but I would say that adrenal medulla, well, they are all same. This is like peripheral nervous system. Peripheral nervous system. These are the some important one. Conotruncal septum, that's important. You have to remember here. Okay. Pharyngeal arch cartilages, parafollicular cells. So these are some important derivatives of neural crest cell that you should remember, on which usually the questions are targeted here. I'm not going into the details of what structures in the eye are derived from the neural crest cell, because I'm sure you must have done in the ophtha part also separately. Let me take you to the options here based on this discussion. Now, if the question here is that N-marked cells, which are neural crest cells, they differentiate into all except. Now, first it says cells of the inferior mesenteric ganglion. Doesn't matter. If it says ganglion, ganglion has to be the part of peripheral nervous system. So it definitely will be derived from the neural crest cells. Option B says adrenal cortex cells. Well, there we got the answer here. It's not the adrenal cortex, it's the adrenal medulla. We have a sympathetic neurons there as well. That is derived from the neural crest cell, not the adrenal cortex. Let's read other options. Cells of enteric plexus. Again, enteric plexus is peripheral nervous system only. Parafollicular cells of thyroid gland, we just said, these calcitonin producing cells, parafollicular C cells, are derived from the neural crest cells. Next in the line, guys, question number 33. Well, question number 33 says, which is correct regarding the azygous and hemiazygous system of the veins here. This also is the question which was asked like 2 years back in the NEET exam. So, when you look at the azygous and hemiazygous system of vein, which is basically draining the intercostal spaces and the thoracic wall, the question usually are targeted to the upper veins, like upper 4-5 veins, which are draining into azygous and hemiazygous. Because in the lower part, it's very simple. The respective vein of the right side will go into the azygos, of the left side will go into hemiazygos or accessory hemiazygos. Once again, I'm going to put a picture for you to discuss this. Now guys, first look into this low resolution only. Now this here is a azygous vein running on the right side, and look at this azygous vein. It enters into the superior vena cava. It makes an arch and goes into the superior vena cava at the level of the T4. At the level of sternal angle, we have this arch of azygos. On the left side, there is no azygous vein. Azygous means unpaired. On the left side, we have a copy of azygous vein in the lower part called as hemiazygous vein, which drains into azygos only. And here we have accessory hemiazygos, which is also draining into azygos. So in a way, I can say that accessory hemiazygos and hemiazygos both are tributaries of azygos. So ultimately, the blood from the intercostal spaces is going to the superior vena cava via azygos. Now the point is, we said azygous vein is entering into superior vena cava at the level of what? T4. So if it is entering at the level of the T4, that means we do not have azygous vein above the fourth thoracic vertebrae. So where other intercostal spaces will be draining, like first, second, third, these intercostal space, when they're going back, are they going to drain into azygous vein or into superior vena cava or into brachiocephalic vein? Well, that is the major question here. Now, look at this. If you're looking at here, this one here is the right brachiocephalic vein. Right? That's a right brachiocephalic vein. And that one is already mentioned. That is a left brachiocephalic vein on the other side. And together they are giving rise to the superior vena cava. The first vein on the right side and the first vein on the left side, they are draining into the respective brachiocephalic vein only. This vein is called as the right first posterior intercostal vein. These intercostal veins are the direction of the blood flowing them in toward the back posterior side. So we call the posterior intercostal vein. Right first posterior intercostal vein and even the left first posterior intercostal vein, they both drain into what? The respective brachiocephalic. What second and third will do, guys? The second and third vein, as you can see, they're joining with the fourth one and they are forming a single vein to drain into the azygous vein, and that vein is called as right superior intercostal vein. As the name says, superior intercostal vein, so it is like the situation is slightly high, so we call it superior intercostal vein. All the three veins unite together and they form a single vein only, and that is called as a superior intercostal vein. Please remember that the word superior intercostal vein does not include first. But as you can see on the left side, the second, third and fourth, when they unite with each other, they're again forming a single vein, but that is also going into what? Brachiocephalic vein and not into accessory hemiazygos. So that is the main question here about these four veins here. Right posterior intercostal vein, right first posterior intercostal vein, where? Into brachiocephalic. Left one also into brachiocephalic. Right superior intercostal vein in azygous vein, but left superior intercostal vein goes into the left brachiocephalic vein. And if you understood this part, now we can fetch the answer to this question. So we got to choose the incorrect regarding the azygous and hemiazygous system here. Right superior intercostal vein drains into azygos. Correct, that's what we saw. Right first posterior intercostal vein drains into right brachiocephalic. Correct, that's what we saw. Left superior intercostal vein drains into accessory hemiazygos is not correct, because left superior was going where? It was going into the left brachiocephalic vein only. So the answer to this question is C. Left superior intercostal vein drains into accessory hemiazygos is not correct. It drains into the left brachiocephalic only. Question number 37. All of the following are present in the superficial perineal pouch except, well, question number 37 is about the content of superficial perineal pouch, and let me point out question number 38 is about the content of deep perineal pouch. Now I'm going to use a very simple approach to two simple diagrams here to make you remember the major contents of superficial and deep perineal pouch. Don't try to remember everything, that is not the point. Let's look into the major thing here. Let me just give you a quick orientation to this. You're seeing this dissected specimen, you're seeing basically it's a lithotomy view, and you can see that's a pelvic diaphragm. This whole thing here is a pelvic diaphragm. Let me just mark it here. That's a pelvic diaphragm, also called as levator ani. The medial part is levator ani. And In below pelvic diaphragm, I mean, obviously below means more superficial. Below pelvic diaphragm, this diaphragm here, the one which is shown with this whitish color here, this is urogenital diaphragm. Now, urogenital diaphragm is having two layers. One is a superior layer which you can't see here, and this one here is an inferior layer of urogenital diaphragm, which is also called as perineal membrane. Guys, look at this, the one which I'm highlighting here. This is the inferior layer of urogenital diaphragm, superior not showing you in there. And this inferior layer of urogenital diaphragm is called as what? This is the perineal membrane. Very, very important, the perineal membrane. Now, perineal membrane is situated in such a way that above the perineal membrane, that means the one which we can't see, that above the perineal membrane, we have a deep perineal pouch, and below perineal membrane, that all that you can see here, everything here which is below the perineal membrane is a content of what? Superficial perineal pouch. So, perineal membrane is the one which is present between the deep pouch and the superficial pouch. In this picture, I can see the contents of what? Superficial pouch. So, I can see what? I can see this muscle here, that is the bulb of the penis and covered with the muscle here. So, this muscle here is the bulbospongiosus, which is covering the bulb of the penis. This muscle here is the ischio. It is coming from the ischium bone and going and covering the cavernous portion of the penis. So we call it ischiocavernosus. Ischiocavernosus is there. Look at this muscle here, guys. This muscle here is a superficial transverse perineal muscle. Well, this muscle is obviously running transversely, and it is present below the perineal membrane. Well, obviously the things which are present below means they are superficial. So this is superficial transverse perineal muscle. Now, the bulbospongiosus, ischiocavernosus, superficial transverse perineal muscle, that these are the contents of what pouch? Superficial perineal pouch, both in male and female. But in case of female, I mean, this is the section of male. In case of female, female, the female gland is also in the superficial pouch. What is that gland? The Bartholin's gland. So if I have to add to this here, apart from this, the Bartholin's gland, which is also called as greater vestibular gland. It's a female gland. So that greater vestibular gland is also the content of superficial perineal pouch. Now you got to remember this male gland, that is Cowper's gland, or you can say bulbourethral gland. It is in the deep pouch. Bartholin's gland, or you can say this greater vestibular gland in female is a content of superficial pouch. Just the major content. So these are the main content that you should need to keep in mind in the superficial perineal pouch. Let me take you back to the question, and then again I'll go to the deep pouch. So here it says all the followings are present in the superficial perineal pouch except, now what we already saw, we saw the muscle bulbospongiosus there. Now we have to justify this other options here, guys. Posterior scrotal nerves and vessel duct of bulbourethral gland, because we said male gland is present in what? Male gland is present in the deep pouch, but the duct of bulbourethral gland has to come down. Now to justify other option, we have already justified one option from here. I need to show you another section here. Okay, now presume that if I take a sagittal section from here, guys, look at this. If I take a sagittal section from this bulb of the penis, well, that section will look something like, let me justify this. This is a sagittal section. This is the bulb and the shaft of the penis here. And this membrane I was talking about is the perineal membrane. That is the perineal membrane, guys. So if that is a perineal membrane, whatever I'm highlighting here, that pouch is what? That is a deep pouch. It is above. It is deeply placed. It is deep perineal pouch. And everything below was a superficial pouch. We already saw the contents of superficial pouch includes what? It was this bulb of penis along with the muscle, bulbospongiosus, ischiocavernosus and all that, right? That is there. What else apart from there will be there? Like in the deep pouch, what is there? In the deep pouch, we have membranous urethra present, guys. Look at this. Membranous urethra is a content of deep pouch 1. Membranous urethra is covered with a sphincter, and that sphincter is called as sphincter urethrae, or you can simply say external urethral sphincter. Internal is close to the neck of bladder. That is a external urethral sphincter is also there. We saw superficial transverse perineal muscle is a content of superficial pouch. This is deep transverse perineal muscle, which is in the deep pouch. Male gland, I told you, Bartholin's gland was a content of superficial pouch in female. In male, the gland is what? Bulbourethral gland, also called as a Cowper's gland. And that Cowper's gland is a content of what? the deep pouch. Just first of all, remember these four contents: membranous urethra, external urethral sphincter, bulbourethral gland, and deep transverse perineal muscle. Now, the thing is, this bulbourethral gland is present in the deep pouch, but when you see this urethra is continuing down here as a spongy urethra, this duct of bulbourethral gland will come down and join like this. So I can say that this duct of bulbourethral gland is present in what pouch also? Superficial perineal pouch as well. Anything that pierces perineal membrane, guys, that's perineal membrane. If any structure is piercing perineal membrane, that is bound to be present in both the pouches, above as well as below. So duct of bulbourethral gland, yes, it is present in the superficial perineal pouch. When you think of perineal membrane, now as I said, if a nerve or blood vessel is piercing this perineal membrane, yes, that is present in both deep pouch and superficial pouch. But there are two things that you need to keep in mind. One nerve called as dorsal nerve of the penis. So there is a nerve, guys, which is running in the deep pouch only and comes down. This is called as dorsal nerve of penis or clitoris. Dorsal nerve of penis or clitoris. And that is the content of only and only what pouch? Deep pouch. Dorsal nerve of the penis comes from posterior side from the pudendal canal itself like this, and it runs in the deep pouch itself. And we have some nerves and blood vessels which are called as posterior scrotal or labial. Posterior scrotal, or you can say labial nerve, as well as vessels, blood vessels also. Posterior scrotal nerves and vessels are the structures which are not going into deep pouch. They're coming directly into which pouch? Superficial pouch. So when it comes to the nerves and vessels, my suggestion to you is, for your exam point of view, you remember that out of all the nerves and vessels you will hear in the perineum, dorsal nerve of the penis is a content of only deep pouch and not superficial. And posterior scrotal or posterior labial nerves and vessel is a content of only superficial pouch and not deep. Rest any other nerve or blood vessel, if it comes in front of you, like deep artery of the penis, artery to the bulb, artery to urethra, this and that, they're all piercing perineal membrane. And if they're piercing perineal membrane, they are content of both pouches. So I'm not bothered about it. I'm bothered about those contents which are unique to either deep pouch or to superficial pouch here. So now let me get back to the question here. So first here we said what? All are the contents of superficial perineal pouch except posterior scrotal vessels. Now here we said yes, that precisely is the content of what? Superficial pouch. Duct, we just saw that duct is coming down and it is also there in the superficial pouch. What is not there? Membranous urethra, we saw it is a content of what pouch? Deep perineal pouch. So that is the answer to this question. Question number 39 says, guys, during the incision and drainage of ischiorectal abscess, which nerve can be injured? Now, ischiorectal fossa, which is also called as ischioanal fossa. Let me show you a picture for this first. Here is a picture again, and this time our focus is not in the urogenital triangle. We are focusing on this triangle, that is an anal triangle here. In this anal triangle, this fossa here is the ischiorectal fossa, no doubt about that. Like that, this is the ischiorectal fossa. We have a lot of fat present in the ischiorectal fossa, and you can have like development of abscess also in that region. What is important to note here, in the ischiorectal fossa, the lateral boundary is by this muscle. Let me mark it on this side. This muscle is forming the lateral boundary of ischiorectal fossa, and that muscle is the obturator internus muscle. This muscle here is the obturator internus. The muscle here is obturator internus. And this obturator internus muscle, guys, which is present absolutely toward this lateral side here, it is covered with a very, very thick fascia, which is shown in there. Can you see that? That fascia over there is called as the obturator fascia. That is obturator fascia only. Made up of the same obturator fascia and contributed by some other also, there is a canal present here, and that canal is called as a pudendal canal. Look at this. There's a canal which is present on the lateral side of the ischiorectal fossa, and this canal is called as a pudendal canal or Alcock's canal. That's a pudendal canal or Alcock's canal. The purpose of pudendal canal is to carry the structures in the urogenital triangle. Like from the posterior side, some nerves and vessels will come in. Like we have pudendal nerve running through it, and then that goes into the urogenital triangle like this. And then we have internal pudendal vessels also running through it and goes into the urogenital triangle. So I say this is a pudendal nerve, and this vessel here is the internal pudendal vessels are also running through it, and they're reaching in what triangle? Into the urogenital triangle. Fine. So if there is an abscess of issue fossa, and while we try to drain that issue fossa abscess by putting an incision in here, the nerves and vessels which are likely to be injured are those which are supplying the external anal sphincter and the anal canal. What you see from this pudendal canal, you will see a nerve coming out in and supplying this region here, and also a blood vessel which runs transversely and supplying here. This is the inferior rectal artery. I'm writing RA, inferior rectal artery, and the nerve here is the inferior rectal nerve. So inferior rectal nerves and vessels are the structures which are running transversely in the ischiorectal fossa, and that is why they are vulnerable to injury when we try to drain the abscess from the ischiorectal fossa, because all other structures are present safe toward the lateral side here. That's why the answer to this question here, where it says that during incision and drainage of ischiorectal fossa abscess, which nerve can be injured? So it is the inferior rectal nerve. Out of the four options which are given here, inferior rectal nerve which is running transversely is most likely to be injured. So question number 47 says, which option is correct regarding the marked layer X in the given slide of the cerebellar cortex? Well, they already said it's a slide of cerebellar cortex, although you can still easily identify the cerebellar cortex slide. Let me enlarge this slide for you. First, let's quickly go through the three layers in there. Now, when you look at the slide of a cerebellar cortex, even if it is at the 4x or 10x, you can easily identify the three layers. The lightly stained outermost layer here, guys, this one here is the molecular layer. That is a molecular layer which is predominantly having two types of cell. We call it the stellate cells, and we got a basket cells. The two type of supporting cells that we have in there, that is stellate and the basket cells. Middle layer. The middle layer is a bit difficult to identify here, but you can see this middle layer in between here is called as the Purkinje layer. This is a Purkinje layer which is having these huge flask-shaped Purkinje cells. The major efferent cells that we have from the cortex, cerebellar cortex, the Purkinje cells are in there. And the one which looks more granular, of course, the one which is marked as X, this innermost layer here is called as the granular layer. That's the granular layer, which is having the granule cells, and it is also having the Golgi cells. So we have three layers of cerebellar cortex from outside to inside. That's molecular layer. Then we have a middle layer, that is a thin layer, but we're having a larger cells in that is Purkinje cells. These Purkinje cells, if I just try to draw one Purkinje cell for you, will have their dendrites in this layer, and the axon will be going like this in this layer, and then obviously out of into the white matter itself. And then innermost is the granular layer, which is having mainly the granule and the Golgi cells. Let's look at the option, and then we'll try to justify the answer to this question. The question here is we have to identify the correct option. What are the correct options in given here regarding the X layer? And that means the question is all about the granular layer. The question is all about the granular layer, which is having the granule and the Golgi cells. It first says it is densely packed with a small granule neurons. So that's why we call it granular layer. So it is correct. It is packed with a granule neuron. That is, this option is correct. Option B says presence of Golgi cells type 1. Now this is where we can, where people might get it wrong. Yes, this is having a Golgi cells. That Golgi and granule cells are two type of cell here. But guys, we have a Golgi cells type 2 present over there, not type 1. It's Golgi cell type 2. Golgi cell type 2. What is Golgi cell type 1? Golgi cell type 1 is a Purkinje cell only. Purkinje cell are the Golgi cell type 1. So Purkinje cells are the one which are Golgi cell type 1. Type 2 Golgi cells are the one which we simply call as Golgi cells, are present in the inner layer, that is a granular layer here. That means option B is not correct. So let me put it out here. Option C says granule cells of this layer receives impulses from afferent mossy fibers. We have two types of afferent fibers coming into the cerebellar cortex. One is the climbing fibers. Now the climbing fibers which will come from the white matter, they are capable of going directly into the molecular layer, and they directly can synapse with what? With the Purkinje cell. Like if let's say this is if I take an example like this, the climbing fiber will come and they directly will synapse I'm writing CF, climbing fibers can go directly above and can synapse with the Purkinje cells. Mossy fibers are limited. Mossy fibers, I'm writing MF. Mossy fibers are those which are only limited to what layer? To the granular layer. So if they are only limited to granular layer, how they are able to reach the top layer, or how will they synapse with the Purkinje cell? Well, with the help of a granule cell present in this layer. So the granule cells are the one which will synapse with them, and then they will reach the topmost layer where they will help them to get connected to the dendrites of the Purkinje cell. These cells here are the granule cells, the only excitatory cells that we have in the cerebellar cortex, the granule cells. Rest all are inhibitory cells. And this junction between the mossy fiber, granule cells, and the Golgi cells also together forms a lightly stained region in between, and that is called as a cerebellar glomeruli. That is called as a cerebellar glomeruli. Glomeruli. So what I said, climbing fibers are going directly and making a synapse with the Purkinje cells. Mossy fibers are reaching only till the granular layer, where they synapse with the granule cells, and the granule cells in turn will help them connect to the Purkinje cell. This synapse between the mossy fibers, the granule cell, and even Golgi cells will contribute to it, is called as the cerebellar glomeruli. They even asked this question once, that cerebellar glomeruli is seen in which layer? It is present in the granular layer. I mean, as a matter of fact, if you see all the cells with the starting with a G here, granule cells, Golgi cells, glomeruli, they are all present in the granular layer only. So let me read the other options here. Other options, we already read option till B. Option C says granule cells of this layer receives impulses from afferent mossy fibers. That's what is happening. These granule cells are receiving the afferent from the mossy fibers. So that is also correct. Option D says the dendrites of granule cells, axons of Golgi cells, and mossy fibers that together forms a lightly stained region that is called as a cerebellar glomeruli. That also is correct. So A, C, and D. There are three options out of these four which is correct regarding the marked layer, correct regarding the granular layer. So answer for this question is what? Option D. A, C, and D are the three correct options. Presence of Golgi cell, yes, it is there, but type 2 Golgi cell. Type